head to toe assessment. We're gonna walk into the room. The first thing we're gonna do is start inspecting the patient right away. We're looking at how the patient looks. Are they awake? Are they alert? Are they asleep? If the patient's awake, you say, good morning, hello, I'm your student nurse, and I'm gonna be taking care of you today. What's your name? And then they'll tell you your name. If they're not awake, then you go and assess the levels of consciousness. Assessment number 1, levels of consciousness. Hi, good morning. I say good morning, and they don't wake up, then I do a little bit of a shake, like tapping or a little shake. Good morning. That's level of conscious number 2. Level of conscious number 3 is painful stimulation. So if this isn't getting it, then we head to noxious stimuli. Noxious stimuli involves this, which is rubbing the sternum with your knuckles. So knuckle rub on the sternum. If they don't respond to that, then you go with nail bed pressure, where you take a pin, you take their finger, and where their nails come out of their finger, you push in like that. And it hurts, like that, okay? And the final one, the very last noxious stimuli, is supraorbital pressure. So there's a little notch above the eyebrow ridge right about here. You're gonna press your thumbs in really hard, presses directly on a nerve. If there's no response to any of that, the patient is probably comatose. So level of consciousness, you grade it from like alert or lethargic or somnolent or obtuse or comatose. I'm sorry, not obtuse, obtunded. All right. You're also going to assess orientation as you're doing that as well. What's your name? My name's so-and-so, I'm going to be taking care of you. Do you know what day today is? Do you know, where you are? Do you know what's going on? And while I'm asking all these questions too, like I've got a whole bunch of questions that I want to ask, I'm doing a physical assessment and asking questions at the same time, because you want to just get in, get out, okay? Are you having any pain today? So, you have a list of most of the questions that you need to ask, so I'm not gonna go over that, okay? What I'm gonna go over is the physical assessment, because that's, so this entire time I'm talking, building rapport with the patient, finding out a little bit about their life, and also asking about, past medical history and this, that, and the other, any ailments that they've had, what brought them into the hospital. Okay, I'll look at the scalp right quick. I might need to use my pen light sometimes. I have them open their eyes. If they can't open their eyes, you open the eyes for them. And I'm assessing pupils, equally reactive and to light and accommodating. If it's like very bright in the room, you may need to bring down the lights to do that one. Then I'll say, okay, can you give me a big smile, raise your eyebrows, lower your eyebrows, okay, open your mouth, I'll take a look in there, stick out your tongue for me, move it left, move it right. So I'm looking at symmetry. Then I'll palpate for lymph node enlargement, okay? And that's my inspection and palpation of the head, okay? That's the first thing. If I was concerned, like, you're not gonna be doing this, but if you were like in advanced practice, if you were concerned about consolidation of the sinus cavities, you might do some direct percussion, but we're usually not gonna do any percussion on our patients in the hospital setting, okay? Next up, I'm moving to the chest wall, okay? I'm inspecting again, inspecting. We're gonna go into a lot of detail about the focused respiratory assessments this week, as far as what you're inspecting for, what you're palpating for, and so forth. But I'm going to inspect the chest wall for any abnormalities, looking for any weird shapes to the sternum or the spine, checking the patient's alignment, looking for things like pectus excavatum or pectus carinum. And then after I do that, I'm palpating, so I'm palpating chest wall, feeling for any subcutaneous emphysema, okay? And then I'm getting the stethoscope, and we are listening. And when I listen for respiratory, I always start with the trachea. So left trachea, right trachea, then the supraclavicular indentations. Also, I'm looking to see if there's any supraclavicular retractions, which would indicate severe respiratory distress, along with accessory muscle use. And then I'm just listening at the second intercostal space, and I go 1, then near the sternum, then on the other side, second intercostal space, all of it in the same row. And then I come down to 3rd and listen, 4th, listen, 5th, listen, 6th, listen. I also, after I finish listening to the front that way, I'm gonna have the patient raise their arm a little bit. And when they, oh my goodness. Hope that didn't break. I think it's gotta be worth a fortune. I have the patient raise their arm a little bit so I can assess axillary. So we listen, and then other side axillary, listen. And you're doing all your respiratory assessments with the diaphragm, not the bell. Okay, while I'm here, another part of the chest is I'm going to auscultate heart sounds. So I go second intercostal space, that's where I'm gonna hear the aorta. So it's second intercostal space, all pigs, down to the Erb's point, eat. Then the 4th space, which is 2, and then the 5th intercostal space at the midclavicular line is M for mitral, which is much. So all pigs eat too much. Another thing that we'll cover when we get to like cardiac, but for now, the main focus should just be on listening for at the different points. So it's second intercostal space, and this a lot of your valves are best heard with the diaphragm. I mean with the bell, not the diaphragm. So we go bell, bell, skip 3, go down to 4th, bell, and then go down to 5th with the bell, and then also go to 5th with the diaphragm because we want the apex, and we're listening for the apical pulse. We can also palpate for the apical pulse. If you have a female client, a lot of the times when you get to that 5th intercostal space, you're gonna have breast tissue in the way, so you can keep the patient covered and maybe come in from the side, and then use the back of your hand always to push that breast tissue out of the way so you can actually listen where you need to listen. You can go over it if the patient has smaller breast, but if the patient has larger breast, then that's going to definitely diminish the sound that you're able to hear. So you want to be able to push the breast tissue out of the way. Okay, so I've auscultated the lungs and the heart now, and that's pretty much all I got to do with the chest wall, unless I'm doing some more focused assessments of the chest wall. And so, when I was palpating up here, sorry, I forgot to mention, when I'm palpating up here, I also take the second to do carotid arteries. Pulses on either side, do not occlude both of them at the same time, left and right. All right, and then we move down. So I'm feeling like muscle tone. I have them lift their arm. Lift your arm for me, please. Hold it, okay, and relax. And I see if they can hold their own arm up. If they can't, then I hold the arm up for them. And I also go, okay, I'm gonna lift your arm up. You tell me when it gets uncomfortable. And I'm checking their range of motion, okay? If they can't move for themselves. If they can, I want to see how, can they like put their arms up over their head? Can they put their arms out in front of them? Like I'm checking all the ranges of motion. So reach down toward your knees, reach up toward the ceiling if they're laying down, and reach above your head, okay? And then reach out to the sides. If they can do all that, then they have full range of motion. If not, I'm gonna note where they have some problems with range of motion. Like maybe they have, on the lateral extension, they have a deficit, and maybe, they can only go to like, so this would be 180 degree extension, or actually based against this plane here. So this would be 180 degree extension. So this would be the 90 degree extension, okay? And if they can't go any more than like 60 or 70 degrees, I wanna make sure that I've noted that. All right, in addition to feeling for muscle tone, I'm looking to check muscle strength. So I have them, lift their arms. Then I also have them squeeze my fingers. So you want them to squeeze your fingers at the same time. A good rule of thumb is to cross your fingers when they squeeze your fingers so that they don't injure your fingers. Because seriously, some clients, especially if they're confused, they'll take it as a challenge to try to break your fingers. If you cross them though, so give me one uncrossed and one crossed. Crossed and uncrossed. So see if you can, here's uncrossed. Feel how that's a little painful?
Yeah.
That's as hard as I can go on too, and that's like nothing, okay? So cross your fingers so that you're not pushing your joints against each other and you really can't feel anything, okay? But you're checking their grip strength, okay? And then also, while I'm at it, I'm gonna check, peripheral extremities for color, perfusion, clubbing of the fingertips, any problems with the nail beds, coming up and checking the radial arteries. If those are good, we got good perfusion, that's it. If I've got poor perfusion on one side, then I'm gonna keep going up and checking the brachial artery. So checking if you have good pulses in the extremities, you don't need to go back up and check any further. But like if the left leg were pale in comparison to the right leg, then I check pulses. If I can't find any here, I need to go to popliteal. If I can't find popliteal, I need to go femoral. So we go up until we, and if I can't find any, then we have an issue. But always we need to double check with Doppler before we call it a day, okay? All right, so we've done chest, we've done arms, right? We also, when we were having them do this, we were inspecting axillary, and if we saw anything in the axillary that needed to be palpated or further looked at, then we would do so, like nodules, lumps, anything like that. Also, for female clients, you want to make sure to ask, like when you're palpating the chest wall, you want to make sure to ask, do you check yourself monthly for lumps in the breast tissue? Do you do self-examination? Do you follow up regularly with your gynecologist to check those? Same for men too. Men can get breast cancer. It's not as common, but it can happen, especially if a man has gynecomastia from medication use or anything like that. You want to make sure you're asking, have you checked, your chest tissue? Men can be sensitive about saying they had breast tissue. So have you checked your pectoral muscles, your big manly pectoral muscles? Have you checked those for lumps recently? So abdomen, okay? We're looking at the shape of the abdomen. This woman here has a rounded abdomen. This is rounded. It's rounded, it's not obese. If it were like really large, not as a result of pregnancy, then we would refer to as obese. Flat is flat, scaphoid is sunken in. So we look at the contour, we inspect, make sure that there's no bruising. Look at the navel area, the umbilicus. You may see like bruising here and there and stuff like that can indicate different things, which we'll talk about as the semester progresses. But inspection, we're just checking the contour. If it looks like it's very rounded and also looks very taut, then it might be that there's swelling inside. And so, we might be leaning toward ascites, which we'll do percussion. We're gonna do percussion with this one anyway. So, for the abdomen, it's different than all other body systems. Usually I'm inspecting, then palpating, then auscultating, then percussing. With this one, I'm inspecting, auscultating, percussing, and then palpating. I don't touch, I just look, and then I'm listening. So I'm listening. I'll start in the patient's right upper quadrant, and I'll listen. If I hear a few gurgles, like clicks like that, then that's good. We got good bowel sounds, okay? If I'm hearing a few of those. If I'm hearing a lot, like they're continuous, like hyperactive, okay? If I don't hear any, I need to listen for a full 5 minutes. The only time I can say that they are that the bowel sounds are absent is if I've assessed each quadrant for a full 5 minutes. And it can happen from time to time. So, but anyway, usually I listen for about 30 seconds. If I hear a couple of clicks and gurgles, then it's present. If I hear like more, it's 5 to 30 clicks and gurgles over a 5-minute period. So that's roughly 6 clicks and gurgles per minute. So if I hear more than 4 or 5, I'll listen for a little bit longer just to make sure it's hyperactive before I move on. But if it's around, 1, 2, something like that, then I'll listen for 30 seconds or so, and then just mark it as, if it's 1, sometimes I'll listen a little bit longer for that second one to click, because if it's 1, 2, 3, or 4 clicks and gurgles over a 5-minute period, then it's hypoactive. And usually if I listen and I hear one, and then a couple minutes go by before I hear another one, I'll just go ahead and mark it as hypoactive. So you're looking for 5 to 30 over a 5-minute period. But now you've auscultated all 4 quadrants, okay? And now you can go on to percussion, comes before palpation. So we'll take your pleximeter, which is the hand that you're going to put close to the surface, and then you use your plexor, and you're going to strike just below your nail bed. And you want to keep your palmar surface parallel to whatever surface you're striking, because that's where you get the resonant sound. That's what echoes the sound. So if I do this here, she's a mannequin, so she's got a very hollow sound to her. This is a hollow sound, right? And this is a dull sound. So when you have resonant, that means you're more hollow sound. So resonance, and your abdomen should be a little bit resonant because you've got a lot of air that fills up most of the spaces in your GI system. You got gases in there at all times. So you've also got fluid in there. So it's going to be resonant, and it's going to be a little tympanic as well. That's that kind of like boingy, springy quality to the sound. What you don't want is dull, because dull areas would indicate that you have some kind of consolidation. Maybe there's like a mass there or a buildup of stool, You don't want dull, and you don't want hyperresonance, because hyperresonance indicates that there's a lot of air stuck in there. Sometimes you can have hypertympany if there's a lot of fluid built up in there. So like with ascites, if you're hitting that and it's like you're thumping a melon, then that's usually ascites, okay? Skin stretched taut. Also, when you're inspecting, you inspect the skin as well. Make sure all over the body you're inspecting the skin as well as you're moving forward, because that's the biggest body system that we're looking at as well. So looking for striation, stretch marks, any old surgical scars that you can ask about, things like that. Okay. So we're continuing to move down. For the groin area, if you are a female client taking care of a male client, actually it really doesn't matter. You should always have someone with you there if you're doing a very detailed inspection of the patient's private parts, But for the most part, if there's like a urinary catheter in there, you just, say, I need to take a look at this urinary catheter right quick, and you take a look right there, and you, see if there's any exudate or any problems, or if the patient, is modest, you might get someone else to come in. Usually it's not going to be a big issue for most patients in the modern day, but you may have patients that are old-fashioned that don't want, males that want only male clients to look at their genitals, and female clients that only want female clients to look at their genitals. So just if you feel uncomfortable, or if the patient feels uncomfortable, bring someone else with you, or let someone else do it altogether. But we're going to be inspecting, the outer genitalia for any exudate, any lesions, bumps, lumps, anything like that. And that's really all we do. There's no percussion. There's no palpation. There may be palpation depending on where you're working. Like if you're working in a gynecology office, you might be doing like bimanual palpation to inspect like the vaginal cavity and the cervix and things like that. On males, you might be assessing for inguinal hernias, like by sticking your finger way up into the inguinal ring and have them cough and see if you feel any intestines popping down through the inguinal ring. But most of the time, you're not doing anything like that at the bedside in the hospital setting unless the patient is there for a specific reason, like scrotal edema. Then you might have to manipulate the scrotum and use like a Bellevue bridge to support, and it's almost like a sling made out of a pillowcase to help keep it elevated so that the swelling will go down, but things like that. So we just take a quick look, okay, ask them if they've been having any problems with bowel movements or urinary issues, and then we move on to inspecting the legs. We inspect the legs, palpate down the legs, taking note of any lesions we see. We're not gonna auscultate or percuss the legs. That's not something that needs to be done. Just like we do with the arms, we're gonna do range of motion, see if the patient can lift their legs up and hold. If they can't, we're gonna do that and see if they have any problems. And then we're going to, assess the toes, assess the toenails, assess the skin, the feet, the bottom of the soles, assess the posterior tibialis and posterior tibialis, dorsalis pedis. If you have any problems finding those, hook your fingers around like you're trying to hook under the ankle, the malleus. Just hook it underneath, and you should be able to find it. Dorsalis pedis, just kind of start off with like 3 fingers going all across the top of the foot. It's usually going to be across this like arch ridge right here, somewhere maybe like 1.5 to 2 inches away from the big toe, toe number 1. But then just like do 3 fingers across like this until you can pinpoint it, and then put your fingers over it. So hook in for the posterior tibialis, and then for if you don't get it from there, the popliteal, just put your thumbs on the patella, and then hook your fingers around them where they come together. That should be where you're able to push up in and feel the patellar pulse. So, and then inguinal is femoral is really easy. You just like go to the junction at which the leg comes into the body there, and it's going to be kind of like right along the middle. You should be able to palpate a femoral. Once we've done the whole front, okay, then you have the patient turn up on their side. You may need someone to assist you with that if the patient's unable to. Then you inspect the entire back for any lesions, bumps, bruises, rashes, redness, pressure ulcers, anything like that. And while you've got them up on their backside, you throw on your stethoscope, and then you listen to so we'll pretend like this is the patient's back. So the breast here are the scapula, okay? You wanna go between the vertebra and the scapula. So you go 1, 2, 3, 4 between the scapula, and then once you start getting the scapula, it's curving off to the sides, then you're gonna go underneath the scapula, and you're gonna branch out further and further until you no longer have any intercostal spaces to listen to. And that's it. So it's usually like on the front it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. It's about 16 on the front, 17, 18, 19, 20, 21 on the sides, and then 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33. Somewhere around 33 to 36 places that you're going to be listening to for auscultating the lung fields. And when you have them up on that side, that's great, because usually if they're going to have any adventitious lung sounds, it's going to be on the posterior because they've been laying down, and that's usually where secretions have accumulated, is toward the back. And that is it. And once you get all that down, you can get this done in like under 15 minutes. My usual head to toe is like a 10-minute thing. I come in there, good morning, how are you, blah, 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 blah. Unless they aren't alert and oriented, that's always a problem. Or if I start having to take a deeper dive into one of the body systems. So if I notice a problem with neuro, when they're doing then I'll do a more focused neuro assessment. I'll go and get my reflex hammer, I'll go and get a cotton tip applicator so I can check for sensation. If they're having respiratory issues, I might end up doing a more in-depth thing where I'm doing things like agophony, whispered pectoraliquy, and tactile firmitis, which you'll learn about this week. Heart, right now you just need to be able to identify S1 and S2, but eventually you should be able to pick up on gallops and murmurs. So S3, S4, and lots of different pitches of murmur. Along with the GI system, when you're inspecting the oral cavity, look at their dentition, look to make sure all the mucous membranes are moist. Essentially, when you're doing that head to toe, the inspection, if something pops out at you as abnormal, that's what you document. We don't worry about the rest. When we're documenting this semester, we only document to the exception. So any normalities, we don't document. Any abnormalities, we're going to document. So it makes documentation real quick and easy, because most of the people in the hospital setting are pretty much normal from head to toe, except for whatever they came in for. Any more questions? No? Okay, cool.